Hello everybody, welcome. It's the infant feeding team here at the John Radcliffe Hospital in Oxford, and we are here for our weekly questions and answers on infant feeding. So if you have got any worries, questions, advice, positive, negative, anything you want to talk to us about this week, this is the forum to do it. If you have questions about your pregnancy or things that you're not sure about your pregnancy, then please direct it to another forum. So Wendy Randall does a session on midwifery care and associated, and also your midwife can answer those questions. We don't work with the antenatal services very much unless it's infant feeding, so we're not as familiar with changes that might have happened in the last few weeks about antenatal services. So please direct your questions elsewhere if they're about pregnancy, not related to infant feeding. Hope that's all right.
Looks like we've already got 18 people watching. Nice
Lovely.
to see you all. Give us a thumbs up that you can hear us and see us all right.
And
I'm just looking for the comments to come up on the laptop at the
that's
moment.
Great. We're just looking to see if we can see the questions to read out for you, so excuse us looking down. So this week we thought we'd talk a little bit about the Oxford Milk Bank, and whether you are familiar or if any of you have heard about the Milk Bank, or some of you may well have already donated milk in the past, or in the present you're doing it. It's a wonderful service that has been around in Oxford for, I don't know, when did it open, do you know?
Oh, the Milk Bank,
quite a long time in the 80s.
Well, it was one of the first milk banks in the UK.
So milk banks have been around for a long time, and you know, in the 1920s in America the first milk bank started. So you know, it's something that has been around a long time, but it's a true gift from women for women, and they work really hard donating their breast milk to us when they've had time or something's happened to them that they want to give back. They may have had lots of support and received donor breast milk with a baby in the neonatal unit, or they may well have had just a really positive experience and have got loads of milk, and they want to give back. So it is every day we've got available milk for the babies in the neonatal unit. That's the priority. So as the supplies go down, the priority is that it always goes to the neonatal unit first, and then if we have any extra, then we can offer it to babies that may be more at risk, that are on the postnatal ward, or the mums that may have got medical problems that need to protect their supply, protect their exclusivity for their babies, let's say gestational diabetics or inflammatory bowel disease, things like that. We support mums or babies that are very small or premature on the wards. We will offer donor breast milk to those babies, and if we have got a surplus, then we will offer it to all mothers if they are struggling to feed their babies on the ward. That is our first offer that we give. So the most important thing that you give to your baby is milk from your breasts, and that's to breastfeed. Then it is to express your own colostrum or milk, and then the next one is to give your baby express breast milk, and then finally you would offer formula unless you chose to give your baby formula, and that's absolutely fine too if that's what you want to do. So we have that available on the wards. We have it frozen and we defrost it, and it's kept in the milk bank just outside the neonatal unit. It's not part of the infant feeding team. There's a lovely lady called Amanda Wood who works in the service, and she knows everything there is to know about it and the process and everything else. So it is available, and when it becomes lower, then we get it. When the levels become lower, then we get less for use on the post.
It's readily available for any baby that we feel that would benefit from it. Any mother who's trying to feed, and it might be just to fill a shortfall while her milk supply is built up, and to keep that baby human milk exclusive. Because as we've talked, you know, about this on these sessions before, exclusivity does give the best health outcomes for babies. So it's, when we're on green, it's readily available for everybody. When we're on amber, it's the babies that have particular health issues. So babies of a diabetic mother, you know, if that mother has diabetes, it does increase the risk of that baby going on to develop diabetes if that baby has formula milk. So we would prioritise those babies to have donated breast milk on the wards. And there are other instances as well, which are negotiable, but that's one of the main ones. mums. And then if we're on red, then it is specifically just for the babies on the neonatal unit. But we're really lucky at the moment, though, aren't we? We've got pictures that we were going to show.
In lockdown, we've had a plethora of breast milk. We've had so many donors that we've been turning people away because you've all been cuddling your babies at home in lockdown and not going anywhere.
Signposting to others the milk banks.
So
this is a picture of what the milk bank freezer looks like when it's fully stocked. This is the milk coming in, so you can see it's all in bags, come directly from the mums, and that's pre-pasteurisation. So that's what it would look like.
And it comes in and they test it. They every mum has, if you want to become a donor, every mum has a blood test. So you had a blood test in your pregnancy, you do have to have another blood test if you want to become a donor, because that's the NICE guidelines, and the compliance with the NICE guidelines is that you have a blood test as soon as you start donating to make sure that it's everything is fine. And then you will, minimum is 6 bottles that they will request that you donate. So you can give a lot more and you can give it much more frequently if you want to, but minimum amount is about six bottles of breast milk. And so what they do is send you a pack with how to do everything, and then you will collect your milk and freeze it at home, and then they will send a courier, and it's the blood couriers on their bikes that come and pick it up. And they come to your house and they will collect it, and then they put it into a freezer, and then they just pasteurize your batch. So each batch is individual, so that we don't mix everybody's milk up. So we know every batch is marked. It has a batch number, it has a barcode, and it's matched to that mother, and so we can trace every single drop of breast milk that a baby gets to the person that it came from. And it's pasteurized and tested for bacteria and for viruses, and it goes through very rigorous testing, and if it's not acceptable, then that is not used.
Yeah, that batch will be discarded.
It will be discarded. So it's really important if you do donate, and this will be on the instructions, is that you're very clean, you wash your hands, your breasts are clean, and the equipment that you use is sterile. And then you collect your milk in the usual way that you would normally do that. And then you would ring and say that you have a stash in your freezer, and someone will come and collect it.
Of liquid gold.
It is absolutely, truly a gift from women to women.
So once pasteurised, it will then be in our freezers, and it will look like this. So you can see all the bottles are done. So we might be in a 100ml bottle or a 30ml bottle, depending on how it's done. And it's all batch numbered, ready for use, and it will get sent out. Some of it will go out to other hospitals in the area that don't have milk banks, for instance, Reading, and the rest of it get used within the hospital.
The other hospitals buy it from us as fundraising to support the milk bank and the costs of running it. So, you know, we help a lot of babies, and actually I think there was a plea put out, wasn't there, for, we had a little shortage, and there was plea put out for more donor breast milk, and it was coming from Scotland and all over, which obviously we didn't take because they needed it in their own areas.
Signposted to their own areas.
But, you know, it worked very well, the powers of Facebook, as you know, on this forum. So we're very specific about the mums that can get it. But also what we do like to say is that if we offer you donor breast milk as a food for your baby while you're in hospital, that you are pumping and you're making and hand expressing in order to match what you're getting, so that you start the process of stimulation. We wouldn't just give it to you and you would sit there and take it like formula. We would expect you to be stimulating your milk and pumping and feeding your baby, if you can, at the breast in the usual way to make milk. So it, you know, mostly people that use it on the ward are giving their own milk with a little bit of donor breast milk. It's not usually just the only food their baby gets. They will be getting normally, unless medically they can't, they're on certain medications or they're having certain treatments where they genuinely can't breastfeed, then that would be a different situation. But actually, when you are offered donor breast milk, we would expect that you would be breastfeeding, hand expressing or pumping in order to stimulate your own milk, to build that supply up while you're in hospital. And we, you know, we support you in that if necessary, or the staff on the ward will support you if necessary.
I want to thank Erica, Michelle and Nicola for giving us some thumbs up. There's some saying they
Hello,
can hear us.
Erica.
I don't seem to have any, it says I've got 3 comments, but I can't see any. I think those were the comments. So if you've got any questions, fire them through, because it's a bit quiet at the moment. You don't want to hear us doing all the talking.
Definitely
So
not.
we'd
We
like
want
your
nice
questions.
variety. What else were we going to talk about today?
Well, baby friendly again.
Oh,
So
yes.
Unicef baby friendly, which is this accreditation we've mentioned before, which all hospitals in the UK are going for if they haven't already got it. And the whole of Scotland is BFI already. It's called BFI. It's not the British Film Industry. It's the Baby Friendly Initiative. So, and it's a mark of, it's a quality mark that hospitals go for, and that's what we're going for at the moment. And it's a 3-stage approach, and apologies if you've listened to us talking about it before, but those of you that are expecting babies at the moment may become part of it for us, because this 3-stage approach involves training our staff, which we've been doing for many years now, assessing our staff, which happened a couple of years ago, and now it's going to be ensuring that our staff are giving you all the right information, and that the next assessment will be interviews with you, the mothers out there. So Baby Friendly, Unicef Baby Friendly, will be running interviews for us in the autumn and into the winter, and interviewing some of the mums that have had babies in the autumn, and asking them if you would get what information you were given. It's not a test of you, it's a test of us. It's
like
to make
Ofsted.
sure, yeah, it's our equivalent of Ofsted. So it's making sure that we're giving you the right information, that you know that actually starting skin to skin with your baby as firstborn is really important, and gets breastfeeding off to the best start. And even if you aren't breastfeeding, that actually having that first feed skin to skin is absolutely crucial for that baby, for that adjustment to life outside the womb, because it regulates their heart rate, their breathing, their temperature. They cry less, so they use less energy, so they're conserving their energy for their change, as that new life outside the womb. So, and they'll ask about whether you were talked to about feeding, and what your thoughts were of feeding, and whether you were taught how to position and attach your baby, and whether you were taught to hand express, because all women should be taught how to hand express, and how you knew that a baby had enough food. And these are all things we're covering in these sessions as well. So it's all the things that we need to, we're getting across to you. And so some of you may be approached by Baby Friendly, and we will ask your permission in advance and interviewed by phone about whether we provided that information to you. So it's an opportunity to let you know that these things are going to happen going forward in the autumn.
It's made a huge difference to a lot of babies and mothers' lives in the world. It's not just in the UK, it's in the world. And many hospitals throughout the world are using this as the gold standard. It's in America as well, and it's a little bit later in America than the rest of the world really, but they're doing quite a lot of it. So it is making a difference to people's lives. For the mother's health, we know that things like heart disease when a mother breastfeeds improves your chances of not developing heart disease. So in America, this is the stats from America, 14,000 women's lives are saved from heart disease, from having heart attacks or heart disease just by breastfeeding. And the reducing the risk of premenopausal breast cancer, ovarian cancer, osteoporosis, all of those things really benefit the mothers that are breastfeeding. But also we know that you are slimmer, so you have less belly fat. If you look sideways on, you have less belly fat. If you breastfeed, you have about up to 2 inches less belly fat on your tummy if you breastfeed. So that is an incentive, isn't it, to do some breastfeeding. And for babies, we know that it does lots of protection for the babies, so particularly premature babies, giving exclusive breast milk to babies in a neonatal unit when they're very, very premature will reduce the risk of them developing something called necrotizing enterocolitis, which is an inflammatory bowel disorder, which is bacterial or infected bowel disorder, which can destroy their bowel and make them very poorly. And we know that babies don't develop that if they just get exclusive breast milk. So that's really, really important, and it's why we give babies breast milk in neonatal units if we can. And also express colostrum. We do freeze in the milk bank colostrum, and that's available for the initial food that newborn babies get if they're in the neonatal unit. So it's crucial that we keep with all of those things, and this is what Baby Friendly does. It raises the profile of protecting babies and why we give it. Things like diabetes, as Alex has already talked about, ear infections, urinary tract infections, asthma, eczema, things like that, is reduced if there's a strong family history. So if you have an atopic history in your family, if you've got allergies to things in your family, it's really, really important that you give your baby lots and lots of colostrum in the early days, and then continue giving exclusive breast milk. And we have talked about that in these sessions before, where you line the gut with the colostrum, and as the baby takes its first feeds, that colostrum lines the whole of the gut and goes into all the little pockets that are in the bowel behind the meconium, and as the baby poos, it lines that gut. The colostrum is a laxative, and as it lines the gut, it coats it all, and it passes the meconium out, so that the baby is literally it's sealed. It's like a sealant that protects the baby from getting infections through the bowel wall, and it protects them from triggers for allergies and things like that. So it's really, really important that these babies get that first food in the early days, to do that, to stop the triggers for allergies later on. And it's not always first thing. It might be that if you give cow's milk protein, which is formula, which is cow's milk, if you give that early on, that could cause the trigger for the allergy when you give the next lot. So you might, if you give one bottle in the first week, you may not notice the difference, but if you introduce it at 6 months again, then you might notice that your baby gets eczema or something. So we know that's tried and tested, that there's lots of research to support that, lots of information. But the more that you give your baby colostrum, the more that your baby is protected, and the more breast milk your baby gets. Every day that you give your baby colostrum and breast milk is a bonus for your baby, whether that's 3 days or 3 months or 6 months or a year. Every day you give your baby is a positive.
And I think it's worth talking about the fact the way that milk changes, breast milk changes constantly. So it's a bit like a ticking clock in the breast, that the breast knows how old that baby is. So the milk is constantly changing to meet the baby's needs, even to the fact that if you have a premature baby, actually the milk that you produce is different to if your baby were born at term. Now, we don't know why that's happened, but it's a fantastic mechanism, because it puts more long-chain fatty acids into the milk, which compensates for the period of time that baby wasn't in utero. So when it wasn't in the womb. So from that point of view, what it does is it promotes brain growth and eye growth. So it's making up for the problems that babies that are born prematurely struggle with. So this milk is changed in a particular way to meet the baby's needs, because the body's going, this baby's early, we need to change it, we need to make sure this is going to be right for this baby. And as the baby gets older, the milk continues to change, and it continues to change all the way through. So for instance, I think the biggest change that we know when we talk about is at about 6 months, babies are beginning to really put things in their mouth, they're beginning to experiment with food, and actually a component in breast milk called lysozyme, which is a fantastic anti-infective, rises greatly at that point in time, and it's there to protect that baby. It's to protect that baby from all the things it's now putting in its mouth, as another layer of protection, because breast milk is so, in fact certainly in the early days, is so much about protection and not just about food.
The baby's first vaccinations, absolutely, it's what they call it, And the other thing is that babies aren't primed for solids before 6 months, because they don't actually have something called amylase in their gut, and that doesn't actually start being produced until about 6 months. So if you give solids before that, the babies can't digest it properly.
No. It just displaces the milk, doesn't it?
It does. So there's a reason for everything, and actually the other thing to say is that the volume of breast milk from about 6 weeks onwards doesn't go up. So you give your baby a breastfeed, and when you give bottles to your baby, you have to keep increasing the volume in the bottles, so they get more and more and more to fill their hunger. But actually with breast milk, the composition of the milk changes, not the volume. So you find that you might only give your baby a certain amount of food in a day, and that won't change at 6 months. It will be the same amount, but the composition of the milk will have different fats, different calories, different components in it that will meet that baby's need. So it's it is truly tailor-made for babies, and it is certainly individually produced for your baby and you. It is unique to you and your baby and your best friend who's breastfeeding will have a different formation of milk, of composition of milk to you, because their baby's needs.
We say it's tailor-made. There's a fantastic video out there. We're going to go and have a look for it. Human milk tailor-made for tiny humans. It's an absolutely beautiful video. Go and have a look. And when you look at the video, it's only a few minutes long, but when you watch the video, you'll see on the background behind the mums that you're watching feeding, there's just lists and lists and lists and lists and lists of ingredients. And those are the ingredients that we know of in breast milk. Breast milk is it's constantly evolving from the point of view of what we know about it. You know, there are so many components in it that it's absolutely incredible. It's an amazing product. And it's a live product. It's fighting off bacteria, which is why we don't worry so much about sterilisation whether you come to using, you know, if you are giving bottles with breast milk in it. But it is well worth a watch.
It was made for an advert, wasn't it? They were trying to get it onto telly for an advert.
Well, it is an advert. You can go watch it. Look on YouTube.
Trying to get it on mainstream telly for people to see. But
it's absolutely beautiful. Go and have a watch. And it picks out certain components that are so unique in breast milk that could never be replaced. And we've actually got a question.
Oh, yes.
Michelina's put us out of our misery.
Thank
you very much. She's one of our top fans. She got a top fan badge. So she says, hello, ladies. My baby girl's now 9 days old. Wow, well done. I'm exclusively breastfeeding at the minute and it's going really pretty well. On day 5, she lost 90 grams, which is 3% of her birth weight.
Yay!
Fantastic. I wanted to ask if my husband will do 1 feed per day from a bottle. Will this make her nipple confusion? I'd like him to have that bonding time too, but not sure when to introduce it. She carries on. She doesn't really burp after feeding. I've heard breastfeeding babies don't burp so often, but wondered if that's okay. She has got hiccups quite often though. Hiccups are really normal. That's really, really common. She probably had hiccups when she was inside you as well. So that's really, really common. I think 3% of her birth weight is fabulous, isn't it?
You're doing a good job there.
I've got another question come up. So just thinking about the husband, so thinking about your husband offering 1 feed a day, we probably suggest you just really get going with your milk supply. Make sure you've got a really well-established milk supply, and then think about introducing the bottle. Just give yourself a little bit longer, not too long, because babies do get to the point where they're going, I don't really want a bottle, I'd much rather it from mum, but maybe just let that milk supply establish, give yourself a couple of weeks, and then think about trying to do it. Babies that have really learned how to breastfeed do cope with the breast and the bottle, and we tend to not have problems. As long as they're getting what they need from the breast, and Naomi's always talking about flow, and the babies need flow, as long as they're getting what they need from the breast, they will very happily go from one to the other and cope with it. But perhaps have a look at responsive bottle feeding before you give a bottle. There's a lovely video on YouTube, another one on YouTube, and that's from the Royal Free Hospital, and that's another infant feeding team, and they did a video about responsive bottle feeding. So if you do a search on YouTube, responsive bottle feeding, it will come up. It's the Royal Free infant feeding team, and they do a very, very good demonstration of what we're looking for with regard to when we talk about responsive bottle feeding. I think Naomi's about to do a demonstration as well.
I'm going to do a demonstration because I can. We have our props as usual. So the whole plan is that I'm going to have to squat.
And I'm going to move.
Yeah. Oops. So the whole plan is that you're. I'll just remove this little tube.
To move the camera.
That's lovely. So that your baby is feeling that it is still at the breast. So if you're trying to breastfeed and you haven't quite mastered it and you're having to feed your baby with a bottle, then this is what we would suggest you keep consistent. Is that your baby is held close, slightly sitting up. And then with the teat, you run it down the top of your baby's nose down to its top lip, and you let the baby gape. By doing that, that will elicit a gape. That's the word, thank you. And so your baby will go, ah, and open its mouth, and its tongue will come out, and then it will take the bottle into its mouth. And then your baby will then take it right in, and you just need to make sure that there's enough milk in this bit. You don't have to fill it all the way up and turn it up like that. If you were to turn the bottle up like this, it would drip. All the time it would drip, and your baby would get a flow, very fast flow, and you'll see that as you're feeding, his eyebrows or her eyebrows will go right up, and they'll go up and up and up, and your baby will be trying to keep up with it. So by putting the flow in, if you just turn that's it, you can then see that the pace is there, and your baby will suckle and pause and suckle and pause, suckle and pause. And the flow will be very different, and your baby's behaviour will be very different. So try not to do that. you're not going to give your baby lots of wind. If you've got enough milk in this little bit here, there's plenty of milk for your baby to be secure from not getting mouthfuls of wind. If you can hear it, then you might just need to tilt it a tiny little bit more, but maintain it at a sort of a level, and then your baby will suckle and pause as it would at the breast, and then when it's had enough, it will spit the nipple out, and they'll be much less windy and much calmer, because they haven't had to deal with a very fast flow of milk while they are having a bottle. And you know, babies that we do see, when we start talking about flow and giving bottles responsively, they take less usually. They don't take as much as you think they need, and they're much calmer because they're not so full. So it's much more responsive to breastfeeding. And so if you're trying to transition to breastfeeding from topping up and giving babies bottles, they're much more likely to respond to breast milk, because that's normally a bit less when they breastfeed than you would give them in a bottle if you traditionally tip it up. They take much less, so it's much more like a breastfeed where they don't have Christmas dinner every day because you want to give them a good feed so they sleep for longer. Doesn't always work like that, as some of you will tell us, but actually your baby will respond to the breast milk and then will go back onto the breast more responsively and more happily if it's not having a really fast flow as it's pouring down and they cough and splutter all the time and you have to keep taking them out and burping them. If they are leading it and they are in control, they are much happier babies, and you will get what they need rather than what you want them to have, which are two very separate things. So always think about responsive feeding when you're doing it, and look at how your baby's behaving. Some babies, when they are having a flow too fast, will look away from you as well. If they can't cope with what's happening,
they'll tell you, watch their cues.
They will look away when you're giving them a bottle, that it's too much for them and they can't cope with looking at you and having a bottle at the same time, so they look away from you. So look at your baby's behaviour, watch what your baby's doing when you're giving it a bottle, and just slow it down if you feel that it's having it too much, and give it a break. Allow your baby to spit the nipple out, the teat out of its mouth if it's not ready to have it, and don't try and give it to them if they don't want it. That's the other thing. Unless actually they're not eating at all and they really need to be fed, and that's a separate issue. But actually look at the way that your baby is responding to you and how you're responding with that, in order to give that baby food responsively in a bottle.
So I think to just do a summary of that then, so Michelina, I think fantastic news that your baby's only lost 3%, so you've done a brilliant job. And I would consolidate feeding, so maybe go another week or so, make sure feeding's going really well. If you're wanting your husband to give the occasional bottle, most women find they've got more milk than they need first thing in the morning. So feed her first and then express, and that milk will do for later when you want to give it. That's usually the time most mothers find they have most milk, which is quite a good time to be doing it. And if that's going to be a regular thing, you're going to express after every morning feed, and that each morning feed, and that will work really well. With regard to the burping, a baby that's at the breast isn't taking air in, so don't worry about the burps. Give her the opportunity to just lift her up, see if she's got anything to bring up, but don't spend ages waiting for a burp that's not going to happen, so don't worry about that. And the hiccups are really normal. That's just normal baby behaviour, so no concerns on that one. But yes, if you want to be introducing a bottle, by all means do. And as long as she's very happy and confident at the breast, she's going to be fine doing both. So I think you'll be
also
fine.
Remember, your husband can do an awful lot of other things to bond with the baby. They can do skin to skin, they can cuddle, they can change the nappies, they can take them for a walk, and give you a break. That's all daddy bonding as well. So partners can do lots and lots of other things apart from just feed a baby, and can be as valuable doing all of those things. So don't be in a hurry to do it unless you have to. So some mums have to go back to work very quickly, and so don't be in a hurry to do it.
I think nappy changing can be great fun as well. It's very often a time when the baby's awake, so there's a lot of, and you're often a good distance from the babies for that face-to-face contact. Babies need our contact with them. They need to see our facial expressions, and they thrive on that contact with you. So actually, it's a lovely time. Yeah. Right. So we've got Vicky's come through saying, I hope that was all right, Michelina. I hope we covered it. So Vicky has said her baby's now 5 weeks and sometimes cries when she's feeding. Why is this?
could be lots
multitude of
different
reasons.
things.
Yeah.
Might have a bit of tummy ache if it's having suddenly a full tummy. Might need to poo.
Yeah.
Quite often they cry because they don't know how to respond to anything else. That's all they can do when something is not right. So it might not be that they're in any problem. It just means that their tummy might be gurgling a little bit and it's a bit uncomfortable. It might be that the flow suddenly got very fast and it's given them a bit of a surprise when they've got it. Any number of things. Is your baby behaving normally? Is it reaching its milestones? Is everything all right with everything else with your baby? Is it well? At 5 weeks, it's not going to be doing anything like teething or whatever. Is that what you say? 5 weeks?
5 weeks. Yeah.
So it's more likely just that they're chatting to you and telling you. But if it becomes a habit and they're doing it a lot, then perhaps you should talk to somebody. But I think if it's just occasionally it happens, it could be that look at your latch. Is there a deep enough latch? We talk about this every week.
That's because it's so important.
Is there pooling in the baby's mouth? Is it spluttering a bit? Suddenly you've got a big letdown, or has the letdown just stopped a bit? As you've got used to feeding, the way that you let down milk is driven by a different system to the initial bit, so that your baby drives the flow of milk. So as you feed, then you start to get your letdown. Not everybody knows they've got a letdown. It's most normal for mothers not to feel a letdown. But what you can see is that your baby suckles more deeply suddenly. So it might be asleep and then suddenly it starts to glug again. And that's where you've had another letdown. It might be that they're waiting for the letdown and it's not coming. And they're waiting for that, and then suddenly the milk comes and then they're happier again. So there's loads of reasons why it might happen. And mostly it's okay. But if it's constant, or it's a problem, or there's milk rejection, breast milk rejection, breastfeeding rejection, where they're averse to going on the breast suddenly and they have a breast strike, then that's different thing, and that's quite difficult to deal with, but much more unusual.
Yeah,
so I don't know if that's answered your question.
So I think if it is on that side of it, the breast aversion, etc., get in touch. If it's just gastrointestinal, because very often, as Naomi said, when a baby's feeding, they're also pooing. So that and babies don't hold in how they're feeling. They tell you in no uncertain terms. They tell you in no uncertain terms if they're going to poo or if they're going to part. Because they just don't. They're just going to let you know that's how they're feeling. Though they don't. So don't sugarcoat it. Yeah. So get in touch if you need us, though. We've got a question from Shay, and I'm really sorry, Shay, but we're not going to be able to answer this one. What's the process of labour when you have strep B? Can we ask you to contact your midwife or go on to one of Wendy's sessions, because this is a very specific labour one, which we are always up to date with and all the information, because we're the infant feeding team. But so Shay, contact your own midwife, or have a quick peek and see when Wendy's next doing her session. I don't know how much time you've got, and then they will be able to let you know what the process is for that. But all the best with your baby, though. Our team at Oxfordshire Maternity Voices Partnership have put a question up that came in their inbox. A baby's nearly 3 weeks old. Their mother's been pumping from day 2, as she was advised to help milk supply, and then there were concerns over his weight being low. But now she's in a loop, and poor you, and it's so tiring, pumping after every feed. How do you move to solely feeding at the breast and reduce or remove the need for pumping and feeding the express breast milk? The baby feeds from the mummy for 5 to 10 minutes and then appears to be asleep. Thank you. Well, I think we're on to our compressions and switch.
Yeah,
do you want to go on to yourself? You're really good at all of that.
The best tool that you can have, and certainly triple feeding, which is what you're involved in, isn't it, with breastfeeding, topping up pumping, breastfeeding, topping up pumping, should be short term. It should never be on and on and on. And depending on how much you're doing your pumping for and what's happening, everybody is individual in this one. But it should be short term. You should be doing it for about 2 weeks, and then it should be turned round, and you should have enough milk in your baby. You should start to see change in your baby's behaviour if your milk supply's gone up, and they should be able to transfer milk. So if your flow and your supply is still not up after that pumping, if you're doing 8 pumps a day, for instance, and your baby's suckling well, but your supply is low, then you need to be looking to talk to us really about that, so that we can do it much more tailored to your individual needs. But one of the best tools that you can use is when your baby is sleepy, is as soon as your baby shows signs of going to sleep, so your baby is suckling at the breast and then shuts down, you do some compression. So compression is holding your breast when your baby's suckling, and then when they stop suckling you let go. So it's not pumping like that, that's pumping. This is compressing, so you're as far back to your chest wall as you can go. So right back here you get a big handful, you can do it like that, you can do it like that. It doesn't really matter as long as you can do it. But you really press the milk in, and you're looking at your baby's suckling. So you're looking at whether your baby's feeding nutritively or non-nutritively. So non-nutritively is nibble, 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 like this. And there's not that deep glug, deep glug, deep glug. Now when you start compressing, you might find that your baby goes from nibble, nibble, nibble to glug, glug, nibble, nibble, nibble to glug, glug. And that's showing that your baby's starting to get more milk from inside the breast. And then as your supply goes up, you do, your baby feeds for longer, and you compress much later, and you notice your baby's transferring milk. So what you do when you've done your compressions and your baby is slowing and sleeping, you take them off that side and you put them on this side, and you do the same again. You're looking at the baby's nibbling, your baby's glugging, and then when they go off to sleep you go back to that side, and then when you go to sleep you go back to that side, and you go back to that side, and you go back to that side, and you go back to that side. You get as many as you can in a feed. And every time you take your baby off, they usually cry and object because they're not finished, but they've closed their eyes. And the reason they've closed their eyes is because the flow's not very strong. And babies are driven by flow. So if the flow is low, they shut down. And as soon as that flow's gone, so they might suckle for a few minutes and then shut down, their eyes will close. And that's when you would take them off and put them on the other breast, and you'd give them flow again on that side. And then you'd go back to that side when they shut down, and then back to this side, and you're constantly giving them mouthfuls of milk by doing that. So that gives them calories, it makes them suckle for longer, and it stimulates your breast milk to produce more milk. So that's the first thing that you would do with a baby that's very sleepy. And it's nearly always flow driven, nearly always flow driven. So look at your supply when they're suckling.
I'm just going to say I'm losing questions off here at the moment because I'm afraid that I don't know why we're not. I can't see all the questions, but I can see as questions are coming in, I'm losing the ones off the bottom. And normally I can go back, but for some unknown reason on this I can't today. So
I can get them on mine.
But
keep with the switch and the compression, and that will up your milk supply naturally. I think as far as your pumping and building up your supply, you shouldn't be doing it for more than 2 or 3 weeks at the very most, and then you should start to see change, and you should be able to then start to challenge the feeding, so that you drop a top up, or you drop a pump if you feel that the baby's behaving, gaining weight, doing pees and poos, all the things that it should be doing. I think we probably need to talk to you. We need to find out exactly what's happening and just see how we can transition you back to normal breastfeeding. It's more, your baby is gaining more weight. I think when you start to see your baby gaining more than it should be gaining, so if you've got a little girl it would be 20 grams a day, and if you've got a little boy it's 30 grams a day about. If your baby, say it's a boy, is gaining 45 grams a day, then you know that you're giving more milk than they may need, but they're very happy to receive it. But you could challenge that. You could maybe not top up for one of the feeds and then see how long they go and then feed them and just see what happens with the weight in a 48-hour period. But I think you need to do that under supervision, and you need to do it with talking to us or your own healthcare professional, so that you don't just go cold turkey. We don't recommend anybody goes cold turkey and just stops topping their babies up, because you will run into trouble if you do that. So I think you need to wean them off. But the parents are the ones that become really concerned about giving bottles and top-ups, because you've maybe had an issue with your baby's weight and you're paranoid about weight gain, and you're obsessed with numbers and volumes and weight, and so you won't let go of that easily. Your baby will let go of it much more quickly than you, but you won't. So you just have to play it by ear, but talk to us, ring us up and let's talk it through with you, so that we can put a plan in place for you to work towards, so that this relentless triple feeding is taken away from you, because it's absolutely punishing.
Yeah, we never intend anyone to carry on expressing
And
the whole way through. Some women do, but it's not the intention.
We know that if you pump for 6 weeks, it takes longer than if you pump for 2 weeks, but full on. And if you do 4 pumps in a day for 6 weeks, it takes a lot. Well, 4 pumps a day, it will take you 6 weeks to build your supply up, maybe. But if you do 2 weeks of, 8 at least pumps a day, you will turn it around much more quickly. So it's about the number of stimulations you do in a day that increases your milk more effectively. Saying that, it doesn't work as well for everybody. So talk to us and we can be individualising with you.
If you see if you can find the ones before Vicky Gardner, who said thank you. She went, that's fab, thanks. See if you can see any other gaps, and I will see if I'll answer the ones we've got here. So bear with me, folks. So Louise has come through, just a quick one. I'm booked to be induced on Sunday and was told by the JR her and her partner have to self-isolate until then. Are we allowed to go for a walk, obviously with no one else, or do we have to fully stay inside? I think self-isolating just involves not being with anyone else, and obviously you need to be careful what you're touching, because we know that it could be on doors, it could be on handles, so just thinking about things like that. From my opinion, I would say that you're probably allowed to go for a walk, because even those that were shielding were, I think, were allowed out in the fresh air. But do check with your midwife if that's anything different, Louise. I'm sorry if I'm not giving you a very clear answer on that. I would have thought going for a walk with just the two of you, taking the usual precautions, should be fine, but do check. Greer has said, how is it best to cope with cluster feeding? As much as you can, go with it. It's very hard. It's usually a phase. It passes after a while. We can never tell you when it's going to pass, and I was always given to understand that it's the baby learning how to take more on board and therefore go longer at night. So we can't tell you how long it will last, but we don't expect it to go on for months. We would expect it, so the first few months be maximum, but it's just following the baby, seeing what they want, doing as much as you can. A cluster feeding would normally be a 2-hour slot, really. If you're finding it's really going on a lot longer than that, then we perhaps need to have a chat and just make sure your baby's transferring milk as effectively as they can, because we would anticipate cluster feeding being usually 2 or so hours, and often in the early evening. If you're finding that isn't the case, Greer, and your baby's doing a lot more than that, then maybe we need a bit of a chat, really, and just to make sure that everything's going well as well as it can be. I hope that answers your question. Did you find the others?
Have you got Elena here? I'm 37 weeks pregnant and I'm unsure on whether or not to buy a breast pump. Is it really necessary to buy one before my baby is born, and do I really need one?
I have, but I've got 2 before, but we can do hers and okay. I'll come back to those as long as I don't lose them.
Yes, certainly buying a breast pump. No, you don't have to buy a breast pump. Some people like to have everything. It's like buying blankets and extra things and baby baths and the whole rigmarole. Most of the things you probably don't need for your baby in the early days, and then you can get them afterwards. But if you feel that you would like to, or somebody's offering to buy you one, you might find that it is helpful to have it, but you can get them afterwards if you feel you need to. But there is also opportunity to hire them.
And borrow them.
And you can also borrow them from your local midwife. So your midwife group have usually got a selection of breast pumps available. They're not always there, but they can normally get one quite quickly if they, they come and go very quickly, because you can usually borrow them for about a week. So they're coming in all the time and going out. Your health visitors also have them. Oxfordshire Breastfeeding Support Services also have them.
Being offered tea.
Yes, please. Oxfordshire Breast Support Services also have some breast pumps, and also you can borrow them from the companies. You can hire them from companies as well if you want to get, say, a hospital grade one.
We can provide you with that sort of information if you email us at all.
So don't worry too much. There are variety of price ranges of pumps and absolute plethora of makes. It's mind-boggling. Don't go and buy the first one you see. It's not always the best one, but if you want to talk it through, talk with your healthcare professional, talk about different types of pumps before you order it. And normally they can come the same day or the next day when you do order them. It's very quick, on the mail order companies online. So there is lots of opportunity to get one. And it may be that you can order it from the hospital before you get home, or you can borrow one from the midwives and then decide whether it's working for you or not.
Yeah, we don't actually have them on the wards as such. We do have them for your use, but not to go home. It's the community midwives all have a few, and they turn over quite quickly.
Charities and things, so
moving on to another question that was before Eleanor's. So Veronica says, hello, I met you before my discharge post-section. Your words were very supportive then, thank you. Victor is now 3 months old. Congrats! Wow. And I've managed to breastfeed with an occasional top-up bottle after lots of meaningful input and support from OBS. They are fabulous at OBS, they really are. And they deserve their holiday that's coming up.
Keep us afloat.
Yeah. I've been on domperidone since week 3 postpartum, tolerating well and no adverse effects. Should I continue on it? Best wishes to all. I think the only way you'll know whether you need to continue on it is to start challenging it a little bit and maybe dropping a tablet and then dropping 2 and then going down to just so you end up on 1. Just see how you do. If you see a noticeable decrease in your milk production, then maybe you need to carry on. We know with domperidone, for some, it's just the boost they need to produce a little bit more milk. For others, they need it continuing to keep that milk supply going. So everyone's different in how they work. So I think the first thing is just to start dropping a tablet and see what happens. Then before you've run out totally, drop 1, then drop 2 and see what happens. And if you see a marked decrease in the amount of milk you're producing, you may need to speak to your GP. And obviously it's totally up to the GP as to whether they prescribe you more, because the way that we used domperidone, it's not licensed for this use. We're using it for its side effect.
It is a drug that you take if your milk supply is a little bit low, and we would recommend possibly taking it for a week. Just to see if it kickstarts your supply. It's what we call a dopamine antagonist, so it drops your dopamine levels and it raises your prolactin levels, so it helps you to produce more prolactin. It's a side effect, it's a travel sickness tablet, and we know that the side effect is that you produce milk if you are lactating. It helps to produce more milk. It's not suitable for everybody, and we don't recommend that everybody takes it, and it's not something that you can get easily. So it's great that you've had it for that length of time. It's quite unusual to take it for that long.
It is totally up to the GP as to whether they prescribe it.
It has to be prescribed by your general practitioner. They know your history, and important that you are monitored when you take it. So it does work, it can be brilliant, but it's not for everybody, and it's not the first thing that we would recommend, and it's important if you take it that you do lots and lots and lots of pumping. You can't just take it and make milk.
So can you just check on your phone, Naomi, we didn't miss any before that, because we've had Louise and Eleanor and Veronica. Before Veronica, just make sure there weren't any there. I'm just going to go back to the ones we've got here. We've answered the pump one. Greer said, thank you very much for the help. The feeds can last 5 hours plus. Can I speak to you separately at some point, please? How is it best to contact us? Give us a ring. Our number is 572950.
Oxford.
That's an Oxford number. It should come up after this, but definitely give us a ring, because obviously that's a long time to be feeding, and I think we can support you. And it would be much better one-to-one, and we can do it on Attend Anywhere, which is a video platform if need be, and if really need be, we would see you in person to help you with this. But I think, Ray, it would be very good if you could get in touch with us. I think it would be well worth it. Have you found any more there?
Louisa, about self-isolating? Her induction?
Yes, for the walk, yeah, we've done
You've
her.
Done that one, have you?
Was there one before?
Yeah, no, we haven't got one before.
No, so which way are they going?
Veronica, we've got.
Yeah. We missed anybody else?
Elena, we've done Greer.
Oh, I think we've done them then, that's fine. Hopefully, if we've missed your question, I'm really, really sorry. So Greer, we've agreed that you're going to get in touch with us, please. The number is Oxford 01865 572 950. That's 572 950. We've got a question that's come through from our colleagues again at Oxfordshire Maternity Voices Partnership from the inbox. Question about the tailor-made milk. If it's tailor-made for a mum and baby combination, how is it that we can donate milk or have a baby receive donated milk from someone else? Because it's still human milk. So human milk is very different to formula milk, which is based on cow's milk, and they modify it obviously for human babies, but it's still human protein, so it's still so that's why donated milk is always in preference to formula milk. So yes, a mother's milk is the first choice always, because it is totally tailor-made for that baby. Her body knows this baby was born early, born late, has been in contact with this infection or whatever, and is allowing for that. The donor milk is not as tailor-made, but it is still human milk. So if we talk about species specific. So it's humans having human milk. So it's still a fabulous milk for a baby to get, whereas formula milk is for all. It's a bit like a one size fits all, and
it's about the proteins in the milk.
Absolutely.
And the proteins in the milk are the things that trigger the allergies.
Yeah.
So the human milk doesn't have the proteins in that cow's milk protein has in, so it doesn't trigger the allergies in the same way.
Yeah.
If there is predisposition to it. It is safe to give to your babies, to give cow's milk protein to your babies. It is a safe form of milk, but it isn't human milk. So the first obvious one, as I said before, is breast milk at the breast and or expressed, and then donor breast milk, and then you would offer formula as the next option.
Yeah. So yes, I completely understand the question. Yes, it's your question. A mother's milk is tailor-made for her baby, and we would always prioritise it. We always prioritise a mother's milk. So even if we've got babies that are on donor milk, the first milk they get will always be their own mother's milk, and then it will be donor milk. Veronica's come back and said thank you. Delana has said, is it possible to give birth at 36 weeks? Yes, many babies are born at 36 weeks. We see a lot of them here. We see them even younger than that, and we have babies on the wards at 34 weeks. It's not ideal. It's quite hard for mums and babies to be born that early. And there are some challenges when babies are born early. They haven't got the same amount of fat, because in the last few weeks of the time in the womb, they're laying down fat on their shoulders, their backs, their legs, their arms, and that fat helps them change, that time of change when they're born, it gives them additional calories that the baby can access. And babies that are born early don't have all that fat. They don't have those fatty deposits to call upon if feeding's perhaps not going as well as it could be. So there are definite challenges when babies are born early, but yes, very, very possible to have a baby at 36 weeks. And that's it on the questions, unless I've missed anyone. So if anybody sent a question through that we've missed, apologies, and if you've got 2 seconds to send it through again, we can answer it now. But yeah, it was a technical issue again.
One of the things that I just want to talk about is about hand expressing and early stimulations as well. We can't say this too often, and we do say it every week for a long time. And one of the things is, don't go for a long time between giving birth to your baby and having a breastfeed initially and then not hand expressing. And this is particularly pertinent to if your baby is separated from you. So if your baby is having to go to the neonatal unit for any reason, and you've given birth and it's maybe had a breastfeed and then it's become a little bit less well and it's had to go for observation. If you're separated and you're on the postnatal ward and or at home or anything, and your baby's not with you, then you should be doing some hand expressions. You shouldn't be sitting there for 12 hours waiting for somebody to tell you to do it. It's so important that you take that initiative yourself and that you think, right, actually, now is the time that I need to get going. My baby's been separated from me. He might be only feeding 3 times in the first 24 hours, but he might be feeding 10 times in the first 24 hours, and you don't know that. You don't know what your baby might have done. So it's really important that if you haven't got your baby with you, or your baby is not showing signs of feeding, firstly do skin to skin. That's the most important thing to say. Take your clothes off, take your baby's clothes off, put him on your chest.
You can have a nappy. They can have a nappy on there.
Have a nappy, because he might make a bit of a mess, especially if he's had colostrum. Do some skin to skin, because that will prime your hormones. And then try doing some hand expressing with your baby on skin to skin, because that does increase the flow of milk in your breasts. And if not, then get some syringes from the midwife, get a little pot, a teaspoon, an egg cup. It doesn't really matter what you use, but do some hand expressing and start to stimulate your prolactin receptors. Start that process going and just keep doing it. Maybe every hour for 3 or 4 hours do it, just for a few, 5 minutes on each breast.
You've got to tell the body the baby's arrived.
Just start that process of hand expressing. Start to stimulate those prolactin receptors so that it's all primed. Don't wait for somebody to tell you to do it. Don't wait for somebody to ask you if you've done it. Just do it. Just start priming your breasts and start to stimulate the milk production and get that process going. It does happen, but it doesn't happen as well if you don't stimulate. So even if your baby's had one breastfeed and they're off on a nice sleep, or they've been separated from you, unfortunately, you've gone to the neonatal unit, just start hand expressing. And I know it's really hard when you've had a difficult birth or your baby's become poorly, you do become quite stressed and anxious and upset by that, but that clock is ticking and you can't turn the clock back.
And it's a really, really positive thing to do if your baby, if you are separated from your baby or your baby's unwell. Just think about this, we've talked about the protective properties of milk lots of times. Colostrum is chock-a-block full of protective properties, and if you and your baby are separated or your baby's unwell, the best thing you can be doing is giving your baby colostrum. It goes back to it's tailor-made. Your body knows your baby's here, your body knows what it needs, and it will make the colostrum specifically for your baby.
If you don't have milk, it's so hard to get back, and you can do anything with breast milk. If you've got too much, or enough, but if you don't have enough and your baby's not feeding well, it's just such a double whammy for you. And there will be mums listening to this session, and they will be saying, yes, get hand expressing, do as you're told.
Mums we've met, many mums we've met.
Don't believe it, just do it, because it is, we can't say it enough. So you cannot say, I'm going to do it tomorrow, I'm too tired. You have to say, I did it yesterday.
Yeah,
you absolutely
unfortunately the body expects that baby to be at the breast, whether it is or it isn't, and it thinks that if you're not removing milk with the baby or with your hand, that it doesn't need to make it, and your body is going to conserve energy and it won't do anything else it doesn't need to do. So even if you're really, really tired, you need to be hand expressing.
And if you have a big stash of express colostrum from the antenatal period where you harvested it when you were pregnant, you still have to do the hand expressing. Just because you've got 40 mils in your fridge or freezer, you still have to do that would be a lot. That would be loads.
That would be
loads
tons.
And loads and
Most
loads.
people don't have that sort of volume. Just to go back to the question, so Delana has come back asking about labour and the speed of labour, etc. Delana, I'm going to signpost you to your midwife if that's all right, because specific questions about labour are much better answered by the midwife that's caring for you, if that's all right. So you can ring and speak to your midwife if you're concerned about anything specifically now. I'm sure the maternity assessment unit would speak to you too if you're worried now, if there's something happening now. So can I ask you to phone your midwife, please, Delana, because I think this is a little bit out of our remit here. All the best with it, and maybe we'll meet you when you have your baby. Livy has said, she's carrying on the colostrum theme, if she expresses her colostrum in syringes before she has her baby and freezes them at home and brings them into hospital because she's having an elective C-section, if they defrost slightly, is it an issue? And how long can the colostrum be defrosted for before use? So it's 12 hours. So colostrum should be used within 12 hours of being defrosted. And what we'd normally recommend is that you only bring some in. Don't bring it all in. And bring it in a cool box with ice, with ice blocks. Try and keep it cool. We do have fridges and freezers, but unfortunately it's actually much better if it stays with you. So if you bring it in a form that it can stay with you, that would be the best situation. Bring a small amount in, because I'm sure your partner or a family friend could drop round with the remainder of it if you need it. And as Naomi said, much as we love you having colostrum in advance, and it's really useful for some of our mums, actually we want you to be expressing as well. So just bring a small amount in. And then keep it in a bag with ice blocks to keep it frozen, and use within 12 hours. Delana's come back again about, is it possible to give birth from 37? Absolutely, 37 to 42 weeks are considered to be normal. We call that term. So a baby that's 37 to 42, we don't put any particular processes in place. We don't do observations on those babies unless there's another reason.
Midwife-led care, unless you are specifically under a consultant. You can have your baby at home from 37 weeks if you're normal, and in an MLU, a midwife-led unit as well, from 37 weeks. So, but anything under that, you would be under consultant care. Yeah.
Greer's come back. Would I give the number again? Right, are you ready? It's 01865 572 950. So that was Oxford, 572 950. And obviously we're not there at the moment. We will be in a minute. So if you want to ring, we can talk to you shortly.
Yes, and so hopefully the numbers will be put in on a link as well. And if they're not, they'll be on the on previous ones if they're not put on there today. Along with Oxfordshire Breastfeeding Support, which I think is on holiday next week.
Yeah.
And so they won't be around to do their Zoom sessions as well. And also, not everybody needs to see the infant feeding team. And you know, when you're in hospital, you might see us coming in and out of rooms and seeing people in the beds next to you, chatting to you. But actually, you know, they probably have got some issue that medically or otherwise that needs a bit more specialist input. But actually, the midwives and the care assistants on the ward, the maternity care assistants on the ward, are able to deal with your positioning and attachment perfectly well, very, you know, carefully. And if they feel that there is a medical problem, if you have got medical problems, then we would then see you, but we won't see everybody on the ward. We can't do that, unfortunately, and the staff are perfectly capable of supporting you in the normal way.
I think that staff would be upset if we saw everybody, because actually most midwives love helping, midwives and maternity support workers love helping with breastfeeding and feeding in general. So I think if we took that away from them, I think they would be a bit disappointed actually, because it's a lovely thing to see get a baby feeding.
It's part of their care.
So from that point of view, I think, you know, as Naomi says, our staff are really well trained and they enjoy doing it, and our students are really good too. Actually, our student midwives are in turquoise. If you meet them, they're really good. They come from we talked about Baby Friendly at the beginning, the Baby Friendly initiative. Their university is Baby Friendly accredited, and so they have fabulous training. So our students are great too.
So in the best possible way, we hope we don't see
you. Yes, please.
If you do, it probably means that you've got something complex going on where we need to support you with your baby. So hopefully we won't see you, but if you need to be around, then we can have, the staff may well call us and ask us if it's appropriate, and we may say no, because we have to individualise our care to the number of people that we have working in our team, and we can't unfortunately you know, take the work away from the midwives and see you if you're normal.
So Livy's come back and said, would 2 syringes be enough? I mean, that's a really good start, and hopefully if you don't live too far away, if you needed more, then actually maybe that, you know, your partner could bring some more back if you need any more. But that sounds like a great start, a really, really good start. Greer's come back and thanked us for the number. Good, we look forward to hearing from you, Greer. Natalie has come through, and I'm just going to put the whole question up because otherwise I always hesitate in the middle. Fabulous. So Natalie's come, she's one of our top fans as well. Hi ladies, I'm hoping to see one of you this afternoon as I've been referred to you. I'm currently on level 5 postnatal. All right, okay. I'm pumping every 3 hours to increase my milk supply. Baby is struggling to latch onto the breast. He falls asleep after a few sucks and I need support with a feeding plan. He's 3 days old. I'm currently topping up with donated breast milk. Those ladies are amazing. Okay. That's nice to hear from you, Natalie.
So
okay.
Hopefully your midwife will be helping you, and then we'll you know, they may well have talked to us already, and we may have said that we, you know, we'll monitor the situation through them if they feel that, or we feel that there's more of a problem.
Yeah.
So your midwife should be able to look after you on the ward unless we feel that there's, you know, a need for us to see you medically.
Okay. I hope that's all right, Natalie. It's nice to think of you just up. We're on level 5 at the moment. We didn't say that at the beginning. We're in room 8-1 on level 5 at the moment, so we're up by the day room. So actually, you're probably somewhere very nearby, which is quite funny to think it's been beamed out and back in again. So I think that's. We haven't got any more questions come through at the moment. We've done our hour. We've done a whole hour already. Thank you very much. The questions are slow to start, but when they got going, they were fabulous. And I hope you found what we talked about from the milk bank useful. And obviously, we're going to keep talking to you about Baby Friendly because many of you are going to be part of the cohort of women that will be interviewed. So it's good for you to know about it in advance and know what we're working towards. So think about your questions for next week. I'm not here next week. It'll be Natalie and hopefully Eliza, one of our colleagues. So
Naomi.
Oh, did I say? What did I say? Did I not say Naomi?
No.
Oh, what did I say? Sorry. It will be Naomi.
I'm Natalie today.
I don't know where that came from. Oh, because Natalie. Sorry, Natalie. It'll be Naomi.
You've
Natalie.
only worked with me for 10 years.
Poor Natalie will be sitting there going, what, me? It'll be Naomi.
You'll be an expert by next week.
It'll be Naomi. Yes, she will be. She could be here. It'll be Naomi, my colleague Naomi, who I do know very well, and probably Eliza next week. So we'll see.
If we can get the equipment to work with that, Alex.
Yes, I still don't do a brilliant job. Anyway, lovely, thank you for all your lovely questions, and be in touch.
We really appreciate you logging in and listening to us.
Okay, and we look forward to speaking to Greer shortly. Okay.
Have a good week.
Yeah. Bye.
Bye from us.